So if you suffer from an asthma attack, you immediately reach for an inhaler to open your airways.
Right. You just want to breathe.
Exactly. You're entirely focused on your chest, on getting oxygen into your lungs. But what if the true long-term casualty of that asthma attack isn't actually in your respiratory system at all?
Which is a terrifying thought.
It is. I mean, is it possible that your pelvic floor is silently paying the price for every single coughing fit?
It sounds completely counterintuitive at first glance, I know. We are so conditioned to think of the body in strict compartmentalized zones.
Right, like the lungs are upstairs and the rest is downstairs.
Yeah, exactly.
Mm.
The respiratory system operates way up in the thoracic cavity, and the reproductive and excretory systems are tucked securely away down in the pelvis. They seem entirely divorced from one another.
Completely separate systems.
But when you examine the actual physics of human movement and internal pressure dynamics, you realize these systems are, well, they're intimately linked by this powerful, almost invisible mechanical force.
Okay, let's unpack this. Because our mission for today's deep dive is to explore a huge stack of medical journals, urodynamic studies, and physical therapy guides.
It's a lot of dense material.
It is, but we are using it to answer a highly specific and frankly mind-blowing question for you today. Can asthma-related coughing actually worsen vaginal laxity?
And to understand how a respiratory condition can degrade pelvic health, you really have to look past the lungs themselves. We need to focus on the hidden mechanics of a cough.
Because it's not just air moving, right?
Not at all. A cough is far more than just a rush of air leaving your trachea. It is an intense, violently coordinated wave of pressure that sends shock waves through your entire core, straight down into the pelvic basin.
Yeah, when we say coughing, we usually just focus on the sensory experience, like the
Right.
tickle in the throat or the raspy sound.
The annoying parts.
Exactly. But digging into the medical literature here, the central character in this physiological drama is something called IAP, or intra-abdominal pressure.
Intra-abdominal pressure is the true variable we have to track here. So let's examine the laryngeal cough reflex, or the LCR.
Okay, what's that exactly?
It's basically an involuntary cough. When a stimulus like, say, an allergen or an asthmatic trigger hits your larynx, your body doesn't just casually push air out.
It panics a little bit.
It does. It triggers a massive, highly coordinated contraction of your thoracic, abdominal, and pelvic musculature.
Yeah.
I mean, it is a full-body ballistic event.
And the physical displacement inside the torso during this event is just wild. Looking at the urodynamic studies in our stack, when that reflex fires, your diaphragm is displaced violently upwards.
It really is violent.
Yeah, the research specifically notes it can be pushed almost to mid-sternal levels during a reflex cough. And while that upward displacement is happening, your abdominal organs are simultaneously being intensely compressed by your contracting abdominal muscles.
What's really fascinating here is the distinct biomechanical difference between a voluntary cough, like, when you politely clear your throat in a quiet room, and an involuntary reflex cough, like an asthma attack.
Right, they aren't the same thing mechanically.
No, not at all. The urodynamic research highlights a critical finding regarding the glottis. During an involuntary reflex cough, the glottis actually stays closed for a significant portion of the muscular contraction phase.
Wait, okay, I need to challenge that logic for a second.
Go for it.
If the entire evolutionary point of coughing is to expel something from the airway, why would the glottis, which is the literal exit door, stay firmly shut while the abdominal muscles are bearing down?
It seems like a design flaw, right?
It seems completely counterproductive to moving air out of the body.
It totally seems that way, until you consider the body's hierarchy of survival needs. The primary evolutionary purpose of that reflex isn't just to expel air, it's actually to protect your airway from aspirating material.
Oh, so keeping stuff out of the lungs is priority number one.
Exactly. The body's absolute top priority is keeping foreign matter out of the delicate lung tissue. So the glottis stays tightly closed initially to seal the airway.
Okay, that makes sense.
By keeping it shut while the abdominal wall contracts violently, the body builds up a tremendous amount of internal force. Only after that pressure reaches a critical peak does the glottis release to generate the explosive velocity needed to clear the throat.
Wow, okay.
But crucially, because the glottis remains closed during that intense buildup phase, it maintains a continuously elevated intra-abdominal pressure throughout the whole torso.
Okay, so imagine your torso is a sealed, water-filled balloon.
I love this analogy.
Thanks. So if you squeeze the middle of that balloon violently and continuously, which is exactly what your abdominal muscles are doing during that closed glottis phase of an asthma cough, that pressure doesn't just evaporate.
Right, it can't just disappear.
Exactly. The laws of fluid dynamics dictate that the pressure has to go somewhere. It radiates outward, pushing fiercely against the path of least resistance.
Which is downwards.
Yes. In the human body, that pressure wave is directed downward, straight against the bottom of the balloon.
That fluid dynamics analogy perfectly illustrates the peril here. The pressure is desperately looking for an escape road. And, well, what anatomical structure is positioned right at the bottom of the pelvic cavity to catch all that violently accelerating downward force?
The pelvic floor.
Exactly. The pelvic floor.
Which is essentially a hammock made up of intricately woven muscles and connective tissue.
Yeah, a very complex hammock.
Its standard day job is just maintaining structural integrity, like holding the bladder, the uterus, and the rectum securely in place against the normal forces of gravity and daily movement.
And it is a remarkably resilient structure. However, a healthy pelvic floor does not simply act as a passive sponge, just absorbing whatever pressure falls onto it.
It fights back.
It actively fights back against the wave. Our sources detail a mechanism known as the cough-anal reflex.
The cough-anal reflex, okay.
Yeah. Electrophysiological studies demonstrate that the perineal muscle contraction that occurs right alongside a cough isn't just a simple binary on-off twitch. The strength of the pelvic floor's contraction is directly proportional to the intensity of the cough itself.
The methodology in the urodynamic studies on this is so fascinating to me.
It's incredibly precise.
There's a specific study in our stack involving 16 continent women. Researchers measured the electromyographic activity, basically the actual electrical signaling firing through the muscles of the anal sphincter during different highly controlled intensities of coughing.
Right. They tested gentle, moderate, strong, and very strong coughs.
And the findings from that electromyographic data completely change how we understand continence and pelvic stability, don't they?
They absolutely do. It turns out that healthy pelvic floor contraction is actually a pre-programmed response engineered by the central nervous system.
Wait, pre-programmed?
Yes. In a healthy, continent individual, the brain anticipates the impending spike in intra-abdominal pressure. It computes the necessary force and sends a neurological signal to trigger a timely, protective compression of the pelvic floor muscles before the physical pressure wave even reaches the bottom of the pelvis.
Hold on, before the pressure hits.
Fraction of a second before, yes.
Are you saying that maintaining a strong, functional pelvic floor isn't just about raw muscular strength?
That's exactly what I'm saying.
Because we treat pelvic health like it's about doing heavy bicep curls at the gym to build bulk. But what you're describing is a split-second neurological timing issue.
It is entirely about timing.
So if my central nervous system is just a fraction of a millisecond late in dispatching that electrical signal, my pelvic floor takes the full, unmitigated impact of the cough.
That captures the vulnerability of the system perfectly. It's not merely about the anatomical bulk of the muscle tissue, it's about the precise coordination of anticipatory reflexes.
That is wild.
When the brain successfully pre-programs that contraction, the pelvic floor activates early. It provides stiffized external support to the urethra and the surrounding fascial tissues, essentially acting as a shock absorber that dramatically reduces the velocity and the acceleration of that massive downward force.
But if there's a delay...
Right, if there is any delay in that nerve conduction, if the timing is off by even a fraction of a second, the biomechanics completely fail. The downward pressure wave crashes into a relaxed, unprepared hammock, and the physical impact on the tissues is just devastating.
Okay, this is where we hit the crucial tipping point in our deep dive. It's one thing if this mechanical failure happens sporadically, right?
Sure, like a random cold.
Exactly. Catching a seasonal cold and coughing for a few days subjects the body to acute stress, which the pelvic floor can typically recover from. But our focus today is specifically on the impact of chronic conditions like severe asthma, chronic allergies, or long-term lung diseases.
The relentless stuff.
We are examining what happens when this delicate neurological and muscular system is subjected to relentless, repetitive stress over years.
And we really have to draw a hard clinical line here between normal, episodic wear and tear and chronic overload. When someone suffers from an asthmatic cough, they are continuously, violently spiking their intra-abdominal pressure.
Day after day.
Day after day, month after month. Over time, that relentless physical force inflicts significant structural damage at a pathophysiological level.
It's essentially structural fatigue.
Yes. The constant, unmitigated pressure physically stretches the muscle fibers beyond their elastic limit. It tears microlesions into the fascial structures, which is the connective tissue matrix holding the pelvic organs in suspension. And crucially, it disturbs the nerve conduction pathways.
Oh, wow. So if the nerve pathways themselves are getting stretched and disturbed by the sheer physical weight of the coughing, that means the electrical signals traveling from the brain are going to be delayed.
Exactly, it creates a lag.
Which means the pelvic floor stops bracing in time for the next cough, exposing the tissues to even more damage, which stretches the nerves even further.
It is a terrifying degenerative feedback loop.
That's a nightmare. And this structural breakdown leads us directly to the concept of vaginal laxity, right?
It does. Now, terminology in this specific area of urogynecology has historically been quite vague, which is why the International Urogynecological Association, alongside the International Continence Society, recently established standardized clinical definitions.
Good, we need standard terms.
Right. They define vaginal laxity strictly as the subjective feeling of vaginal looseness. Clinically, it's described as the vagina demonstrating an exaggerated capacity for distension, resulting in a profound loss of tissue elasticity and tone.
Now, reading through the guidelines, it is very important to distinguish vaginal laxity from pelvic organ prolapse, or POP,
Very important distinction.
because prolapse is a condition where the structural failure is so severe that organs actually physically herniate and bulge down into or out of the vaginal canal.
Right, like a cystosol or a rectosol.
Exactly, where the bladder or rectum collapses into the wall. Laxity is a distinctly different diagnosis. With vaginal laxity, the surrounding organs might still be generally in the correct anatomical position, but the vaginal tissue itself has completely lost its tension and structural integrity.
Though the research is quick to point out that laxity is frequently a precursor to and linked with prolapse symptoms.
They're related.
Oh, absolutely.
Yep.
They exist on the exact same spectrum of pelvic floor dysfunction driven by the same mechanical failures. And when you start layering the risk factors, you clearly see how a chronic asthmatic cough acts as a massive physiological amplifier.
Adding fuel to the fire.
Exactly. Consider a patient who is already experiencing the natural tissue changes associated with aging, specifically declining estrogen levels. That naturally leads to thinning vaginal walls, decreased blood flow, and a baseline loss of elasticity.
Sure, menopause factors in.
Or consider a patient who has sustained previous microtraumas from childbirth, where those pelvic muscles and nerves were already severely overstretched.
So, if you take a pelvic floor that is already compromised by declining estrogen or past childbirth, and you introduce the violent, relentless intra-abdominal pressure of a chronic asthma cough, you've essentially engineered a perfect storm for structural collapse.
The absolute perfect storm.
Think about a safety net positioned high up under a trapeze artist.
Okay, I'm visualizing it. How does the trapeze net hold up against chronic force?
Well, if the acrobat falls into the net once, which mimics a normal temporary chest cold, the net catches them easily.
Right, it does its job.
The ropes stretch, they absorb the kinetic energy, and immediately bounce right back to their original tension. But if you take a heavy anvil and drop it into that exact same net repeatedly, violently, day after day, year after year,
That's the asthma cough.
that represents the closed glottis asthma cough. The physical fibers of the ropes are eventually going to exceed their tensile strength. They stretch out and they stay stretched out. They permanently sag.
That's a great way to picture it.
And that structural sagging, that total loss of recoil, is exactly what the exaggerated capacity for distension and vaginal laxity looks like.
The clinical reality of that sagging net has profound implications for a patient's daily life, too. The medical literature points out that vaginal laxity is a stark indicator of poor overall quality of life.
It's not just a physical symptom.
No, it's deeply psychological. The loss of tissue tension leads to significantly diminished physical sensation, which directly correlates to reduced sexual satisfaction and can profoundly erode a person's psychological confidence and self-esteem.
Which makes total sense.
Furthermore, that same chronic pressure degrading the vaginal walls is a well-established contributory cause of stress urinary incontinence. The damaged hammock can no longer keep the urethra sealed, resulting in urine leakage during those exact same coughing fits.
It is genuinely staggering to realize that a respiratory condition, an issue fundamentally dictating airflow in the chest, can so mechanically dismantle pelvic health.
It really is all connected.
But we don't want to leave you sitting there with nothing but this grim biomechanical reality.
Definitely not.
The human body is incredibly adaptive, and its capacity to heal and be actively retrained is remarkable. So let's pivot to the clinical solutions outlined in our research. How can you actively protect your pelvic anatomy from the collateral damage of your own lungs?
Well, the absolute first line of defense is always going to be addressing the root source of the intra-abdominal pressure. You must treat the underlying respiratory cause.
Stop the cough first.
Exactly. If poorly controlled asthma or severe environmental allergies are triggering the chronic reflex cough, managing those conditions medically with your physician is paramount. Returning to your analogy, you have to stop dropping the anvil into the net before you can realistically begin the work of repairing the frayed ropes.
That's step one. But even with optimal medical management, asthma attacks and coughing fits are still going to happen occasionally.
True, you can't prevent every single cough.
You still need a tactical way to protect the pelvic floor when the pressure spikes. Our physical therapy sources outline a highly specific, deceptively simple technique recommended for patients with chronic lung conditions. In the clinical literature, it's referred to as the knack.
Yes, the knack. It is a foundational protective maneuver. The technique involves consciously, intentionally, drawing up the muscles of the front and back pelvic passages right before you anticipate a cough, a sneeze, or before lifting a heavy object.
So you're bracing yourself.
Yes, you are essentially using conscious thought to execute the brace that your central nervous system is supposed to be doing automatically.
You are manually overriding a delayed or damaged neurological reflex.
Exactly. It's a manual override.
Think about the last time you had a terrible respiratory infection or a violent allergy attack. Did you ever stop to consciously brace your pelvic core before a coughing fit hit you?
Probably not.
Let's be honest, almost none of us do. We focus entirely on our throats. We reach for a lozenge or a glass of water, completely ignoring the structural integrity of our lower half until it's far too late.
And then we suddenly realize we've leaked urine.
Right, or we feel that heavy, concerning dragging sensation in the pelvis.
It is a universal human habit. We completely dissociate from our pelvic region when our lungs are in distress. We retreat into our upper chest. And that exact disconnect is where the broader, more comprehensive role of pelvic floor physical therapy becomes critical.
It's so much more than just the basics.
The urogynecological guides in our stack are very explicit about one thing. True pelvic rehabilitation goes far beyond just telling patients to do simple Kegels while sitting at a stoplight.
I noticed the physical therapy clinics heavily emphasize that point. Why is the classic advice of just do your Kegels fundamentally insufficient for a patient dealing with an asthma-induced pelvic issue?
Because, as we discussed with the electromyographic studies earlier, isolated muscle weakness isn't the primary failure point. The nerve conduction and the timing are.
Oh, right, the timing is off.
Exactly. If the nerves have been disturbed and stretched by years of chronic coughing pressure, just repeatedly squeezing the muscle in isolation doesn't fix the communication delay.
It doesn't fix the lag.
Right. Modern urogynecological physiotherapy focuses heavily on retraining the entire neuromuscular pathway. Therapists work to integrate proper diaphragmatic breathing mechanics, teach patients how to dynamically manage intra-abdominal pressure, and instruct them on how to recruit the deep abdominal core and the pelvic floor simultaneously as one coordinated unit.
So they're training the brain as much as the muscle.
Exactly. The goal isn't just a stronger muscle. The goal is rebuilding that anticipatory reflex so the brain and the hammock communicate efficiently again.
So what does this all mean when we put the pieces together? Let's quickly recap the mechanical journey we've just mapped out for you today.
Let's do it.
We started with an asthmatic trigger in the lungs. We learned that the body's protective reflex to keep the airway clear results in a closed glottis and a massive violent spike in intra-abdominal pressure.
The water balloon squeeze.
Exactly. That pressure acts exactly like squeezing a sealed water balloon, sending a relentless, accelerating wave of force crashing down onto the pelvic floor hammock. Over time, that continuous physical hammering stretches the delicate tissues.
It disrupts the critical nerve signals that time our protective bracing.
Right, and it directly contributes to vaginal laxity, which is a literal structural loosening of the anatomical safety net.
But the empowering takeaway from the clinical data is that permanent structural degradation is not an inevitable conclusion. By recognizing the physics at play, we can actively intervene.
We aren't helpless here.
Not at all. We can utilize targeted techniques like the knack to manually brace against the pressure spikes, and we can engage in specialized physical therapy to rewire our own brain-muscle connection, actively managing the internal physics of our own bodies.
Learning about the sheer physical force of a single closed glottis cough completely changes how you view a simple clearing of the throat, honestly.
It forces a total shift in perspective regarding bodily mechanics. And, it leaves us with a much deeper physiological mystery to consider.
What's that?
Well, we've seen today, through electrophysiological data, that the central nervous system is constantly attempting to pre-program our pelvic floor. It's running split-second calculations to brace our tissues against the violent impact of our own respiratory system.
Right, it's doing math in the background.
It's a hidden background process entirely dedicated to preserving our structural integrity. It genuinely makes you wonder if our brains are constantly executing these silent, complex mathematical equations just to protect our anatomy from basic bodily functions like coughing.
Yeah.
How many other automatic movements or habitual postures are we engaging in every single day that are silently reshaping our internal structures, stretching our tissues, and altering our nerve pathways without us ever even realizing it?